What's up, everybody, and welcome to the Super Nurse Podcast. I'm Brooke Wallace, ICU nurse, transplant coordinator, clinical instructor, and creator of Super Nurse Comics. I personally research and clinically review every episode before our AI hosts bring it to life. With the latest research and best practices mixed up with my real-world experiences, we're going to help you be the super nurse you were born to be.
You walk onto your unit, you take report, and immediately your eyes are scanning the floor.
Right, you're looking for your highest acuity patient.
Exactly. You're bracing for the obvious emergencies, the post-op hemorrhage or like the crashing respiratory failure.
Yeah, the loud ones.
Right. But the reality is the most common and potentially dangerous substance emergency you're going to face on the hospital floor isn't always obvious at first glance. It's not bleeding.
No, it's often a patient just sitting quietly in bed.
Yeah, but their physiological clock started ticking the exact moment they hit your unit.
It really is the ultimate hidden time bomb. I mean, a patient comes in for a routine elective surgery or maybe a mild infection.
Right.
And because the care team doesn't catch the subtle clues early, 24 hours later, that same patient's crashing into a life-threatening, neurologically catastrophic crisis.
Which is alcohol withdrawal.
Exactly.
Well, welcome to the Super Nurse Podcast. The material for today's session was created by Brooke Wallace.
And Brooke is a 20-year ICU nurse, an organ transplant coordinator, clinical instructor, and published author.
Yeah, she is. Now, we should clearly explain that we are not Brooke.
Definitely not.
We're your guides, basically utilizing Brooke's bedside knowledge, her notes, and that really gritty, experienced ICU teaching style.
Because we want to help you, whether you're a nursing student or a brand new nurse, we want to help you connect what you learn in school to real patient care.
Totally. And before we get started, we want to invite you to subscribe and watch the comic book-based video version of the show on YouTube.
Yeah, the channel is called Super Nurse Comics, and the link is in the description. The visuals are amazing for this stuff.
They really are. So let's lay out the mission for today. We need to demystify alcohol use disorder, or AUD.
Right, we're going to break down exactly what happens in a withdrawing patient's body.
And outline the nursing assessments and interventions you need to keep them safe. So let's start with the basics. What is AUD in plain English?
Well, it's not just a bad habit, right? I think people tend to look at it that way.
Yeah, there's a lot of stigma.
Exactly. But clinical experience shows it is a chronic, relapsing brain disease. It's really characterized by compulsive drinking and a total loss of control.
And when you say brain disease, that's literal, right? The brain physically changes.
It does. To make this easy for the bedside, let's use a car analogy to explain the central nervous system.
Okay, I love a good analogy.
So alcohol is a central nervous system depressant. It acts like a incredibly heavy brake pedal on the brain.
Meaning it enhances GABA, right? The inhibitory neurotransmitter.
You got it. GABA is the brake pedal. So when a patient drinks heavily for a long time, the brain realizes it's constantly being suppressed.
Right, it's always fighting that heavy brake.
Exactly. And to keep the heart beating and the lungs breathing, the brain physically hits the neurological gas pedal, which is glutamate.
Oh, wow. So it's flooring the gas just to overcome the alcohol?
Yes. It's trying to find normal while the brakes are slammed on.
This is such a massive aha moment for bedside nurses because the golden rule of the bedside is that intoxication and withdrawal are almost always opposites, right?
That's the golden rule, yeah.
So when the alcohol, which is the brake, is suddenly removed when they get admitted, what happens?
The brain's gas pedal is still absolutely floored.
Oh, man. So that leads to a dangerous, hyperactive spike in vitals.
Exactly. The engine is just redlining with no brakes.
Okay, let's unpack this for a second because I have a question.
Sure.
If alcohol physically remodels everyone's brain over time like this, why does one person develop severe AUD while someone else who drinks socially for years just doesn't?
That is such a good question.
And what makes a patient vulnerable in the first place?
Well, addiction isn't just about exposure to a substance. It is a really complex collision of genetics, environment, and psychology.
It's never just one thing.
Right. And the research shows that genetics actually account for 40 to 70% of an individual's risk.
Wait, really? Up to 70%?
Yeah, it's huge. And then you add other massive factors on top of that, like the age of first use.
Meaning when they started drinking?
Yeah, if it's before age 18, it drastically increases the risk.
I guess because the adolescent brain's reward pathways are still forming, so they're super sensitive.
Exactly. They get hardwired for it.
Yeah.
Plus, you have co-occurring mental health disorders and severe psychosocial stressors.
Like adverse childhood experiences, right? ACEs.
Yeah, ACEs or trauma, like PTSD, they're often self-medicating a nervous system that's been dysregulated for years.
That makes a lot of sense.
There's also this clinical nuance we need to mention called the telescoping effect.
What is that?
Clinical evidence tells us that women who use alcohol or opioids actually often progress from initial use to a severe disorder at a much faster rate than men.
Oh, wow. So it's physically taking a heavier toll faster.
Yes. And understanding all these risk factors is just so crucial for nurses. It really helps build empathy.
Right. It helps you recognize that the patient in front of you might not fit a stereotypical mold. You have to drop your assumptions.
Exactly. You drop the assumptions and you focus on the physiology.
So now that we know why patients are vulnerable and what is happening with that gas pedal in their brain, how do we spot it when they get admitted?
Right. How do we actually catch it on the floor?
Yeah, because we need a timeline.
Mm.
And there is a highly practical clinical tip for this.
My favorite tip.
When you're doing an admission assessment, always ask the patient exactly when they had their last drink.
But you have to do it with zero judgment. No lectures, no raising your eyebrow.
Right, just casual. You just want the data.
Exactly, because that timestamp acts as your bedside timer. It helps you predict when withdrawal symptoms are going to peak.
Okay, so let's walk through that pattern recognition. What happens at 6 to 24 hours?
That's when mild to moderate symptoms begin. The nurse is going to see the heart rate start to climb.
Tachycardia.
You'll see hypertension, anxiety, diffuse sweating, and nausea.
What about physical clues we should be looking for?
You want to look for fine tremors, like watch their hands when they reach for a cup of water or their morning meds. If they're shaking, pay attention.
But wait, a patient with a broken femur might have a fast heart rate and be sweating just from severe pain, right? Or maybe an infection.
Oh, absolutely.
So how do we differentiate between pain or sepsis and alcohol withdrawal? It seems really confusing for a new nurse.
It is confusing, but this is where clinical judgment comes in. And we have a tool for it. It's called the CIWA-Ar scale.
The Clinical Institute Withdrawal Assessment.
Right. It allows nurses to quantify the severity of very specific symptoms.
So you're not just guessing based on a heart rate. You're scoring their tremors, their anxiety, their sweating.
Exactly. Are they picking at imaginary things in the air? You score all of that, and it actually guides your medication dosing.
Okay, so what happens if we miss those early signs or we just fail to treat them effectively?
That is when the patient enters the severe window, the danger zone.
And that leads to life-threatening complications.
Yes. The most well-known is delirium tremens, or DTs.
That sounds terrifying. When does that happen?
Usually 48 to 96 hours after the last drink. It is an extreme autonomic hyperactivity response.
So we're talking high fever, severe tachycardia, new onset of hallucinations.
Yes, and potential withdrawal seizures.
Wait, I thought seizures could happen earlier than DTs.
They can. Seizures can actually start as early as 8 hours after the last drink, but they typically peak around 24 hours.
Okay, so you have to be on high alert immediately. But there's another major complication we have to talk about, right?
Wernicke's encephalopathy.
Right. This is a critical complication caused by a massive deficiency in thiamine, which is vitamin B1.
Exactly. These patients are usually severely malnourished, and alcohol blocks thiamine absorption anyway.
Here's where it gets really interesting, thinking back to the car analogy.
Yeah, let's bring the car back.
Think of thiamine as the spark plug. It's what allows the brain to convert glucose into usable energy.
Right, you need the spark plug for the fuel to work.
So, if you give a withdrawing patient IV glucose without giving them thiamine first, it's literally like flooding a car's engine with fuel, but having no spark to ignite it.
It's so dangerous.
The brain essentially stalls out, causing irreversible damage.
Yeah, that is a huge clinical pearl. Never give the glucose before the thiamine.
Or else you're going to see sudden vision changes, right? Like nystagmus.
Yes, their eyes will involuntarily twitch. You'll also see ataxia, which is an unsteady gait, and severe confusion.
And if left untreated, it becomes Korsakoff syndrome.
Which is an irreversible memory disorder. They basically lose the ability to form new memories forever.
That is devastating. So understanding that danger means we have to anticipate the provider's orders. We have to protect the patient.
Exactly. So let's talk about the action plan.
Safety first, obviously. The ABC's airway, breathing, circulation.
Right, but you also have to implement seizure precautions and strict fall precautions immediately.
Because if they have ataxia and tremors, they are going to fall.
Yeah, they can't walk safely.
And what about their mental state? Because alcohol abuse increases suicide risk, right?
Significantly, their anxiety is through the roof, so suicide precautions may also be necessary, depending on your assessment.
Okay, what about the room itself? Bedside care.
You need to provide a low-stimulation, quiet, and evenly lit environment.
Evenly lit is interesting. Why not just dark?
Because shadows in a dark room can look like hallucinations to a hyperactive nervous system.
Well, that makes sense. You don't want to agitate them further.
Right, keep it calm and clear.
Okay, so what anticipated medications are we looking at?
The cornerstone is chemical station, usually with benzodiazepines like diazepam.
Oh, because benzos act on the same receptors as alcohol.
Exactly. They are used to temporarily replace the alcohol brake pedal.
So you're easing the brakes on to prevent seizures and DTs.
Yes. And we also anticipate orders for vitamins.
Right, 5-ethyamine again, before glucose, plus folate and multivitamins to correct those nutritional deficits. And we also have to manage fluids and electrolytes.
Yeah, you'll hang IV fluids to correct dehydration from all the sweating and vomiting.
And replace their magnesium and potassium, because alcohol just depletes all of that.
It really does. So you are monitoring vital signs very frequently to catch any extreme autonomic responses early.
So let's say the patient is physiologically stable now. They made it through the danger zone. Our nursing role kind of shifts at that point, right?
It does. It shifts to patient education, psychological support, and basically a warm handoff to long-term recovery.
Which means we need to use screening tools.
Yeah, tools like SBIRT, That stands for screening, brief intervention, and referral to treatment.
But the one I see used a lot at the bedside is the CAGE questionnaire.
CAGE is incredibly practical.
Right, it's an acronym. C is, have you ever felt you should cut down on your drinking? A is, have people annoyed you by criticizing your drinking?
And G is, have you ever felt guilty about your drinking?
With the E being eye-opener, right? Like having a drink first thing in the morning to steady your nerves.
Exactly. And you don't just grill them with these questions. You weave them naturally into your conversation while you're giving care.
Yeah, it opens the door to discuss long-term interventions, which are highly customized for every patient.
Right. They might need cognitive behavioral therapy, or CBT, to improve coping skills.
Or support groups like AA or Smart Recovery.
Even pharmacology for AUD, like naltrexone or disulfiram, once their cognitive status permits.
But I think the most important thing here is the nurse's tone.
Absolutely.
We really need to emphasize offering hope, treating them with dignity and setting the expectation of recovery.
That compassion is just as important as the medication.
It really is. All right, let's summarize the most important lessons today so you can take them to the bedside.
Number 1, remember the brake pedal and gas pedal mechanism.
Number 2, use the exact time of their last drink as your bedside timer.
Great. And number 3, closely monitor their vitals and that CIWA scale.
And always anticipate safety hazards like seizures and, of course, Wernicke's encephalopathy. Thiamine before glucose.
Always.
The emotional takeaway here is that with this knowledge, a new nurse does not need to be intimidated by withdrawal.
No, you have the clinical judgment now. You can predict the physiological cascade and get ahead of the crash.
But we want to leave you with one final, really provocative thought to mull over.
Yeah, it's this concept called the kindling effect.
What's fascinating and honestly terrifying is that each time a patient goes through this cycle of heavy drinking, withdrawal, and relapse, their brain actually becomes more sensitized.
Yes, the subsequent withdrawal episodes actually become neurologically worse and way more dangerous.
It physically lowers their seizure threshold over time, right?
It does. It increases the risk of seizures and makes future relapses even more likely.
Which just highlights exactly why early effective nursing intervention is so critical. You're not just treating them today, you're protecting their brain's future baseline.
Exactly.
Well, thank you so much for joining us, reminding you to watch the video on YouTube at Super Nurse Comics.
Yeah, please like, subscribe, leave a comment, and let us know what you thought.
And make sure to visit supernurse.ai for great resources to help you become the super nurse you were born to be. Catch you next time.